peculiarities of the venous system of the lower limb. It is different than the upper limb. Why it is different, can you tell me? Gravitation, yes, because we are standing, because of upright posture. That doesn't happen with the upper limb. The venous blood from the lower limb has to be sent to the heart, isn't it? So there is an anti-gravity. That has to be there. Secondly, there is a unidirectional flow. You cannot have a blood which is going up and also coming back. So what body has done, what the God has given us is one, unidirectional flow. Second, presence of valves which allow this unidirectional flow, which prevents the backflow of the veins, blood in the veins. Then God has also given us two sets of venous system. One for the superficial, one for the deep. And in between you have something called as a pump. Up till now we were talking about only the calf muscle pump. But now there is this concept of the muscle pump in the foot, muscle pump in the thigh. All of them have been identified, and that is what aids this venous drainage towards heart. So we need to understand this. Why we need to know that there is a superficial venous system, deep venous system, and there is something called as the communicating vein in between. Because unless we know this connection, we will not be able to understand what goes wrong. Why do some people get varicose veins, some people don't get varicose veins? Or what is secondary varicosity meaning? Okay, so there is anti-gravity, unidirectional flow. Main venous drainage is from the deep venous system, because that is where you have the pump which pumps the blood from the deep venous system towards heart. So unidirectional flow from superficial via the communicating to the deep and then towards heart. That is the flow. So there is a foot pump, calf muscle pump and a thigh pump. So this will make it more easier. So what we have is in the superficial venous system, you have a long saphenous vein which runs on the medial aspect of our leg, and the short saphenous which is not on the lateral but posterior. So this is very, very important. If you are looking at a varicose vein patient, you have to see the patient from behind. Okay? Otherwise you will miss the short saphenous venous system varicosities or dilatation. So medially all of us are aware, but short saphenous is not lateral, it is behind. It is almost in the midline over the calf region. Okay? So you have to be aware of this, and there is something called as a communicating vein. Okay? So if you see here, yeah, so this is the deep vein. This is the deep fascia, and these are the superficial veins. So skin, superficial vein, there is a communicating vein and the deep vein. See the caliber, difference in the caliber also. There are two types of communicating veins. So this is a direct perforator or a direct communicating vein, and this is something called as the indirect perforator. And we as surgeons are afraid of these indirect perforator. Why? Because these are the seat of maximum deep vein thrombosis. Okay? So direct perforators and indirect. So when you see a big blowout, are you aware of what is a blowout? Blowout is when you have an incompetent perforator. I think you all are aware of the terminology incompetent perforator. You must have read the Doppler report of many of these varicose veins. So what is the function of perforator? Is to allow a unidirectional flow from the superficial venous system to the deep venous system. That means there is a valve sitting here. Now, when can I call this perforator incompetent is when that valve loses its function. That means instead of allowing just a unidirectional flow, it allows the blood to backflow. So that is what I mean by incompetent perforator. So suppose this particular perforator, which is a direct perforator, there is a direct identifiable deep vein, identifiable superficial vein. Now this becomes incompetent. That means the blood from deep venous system, when the calf muscle pump starts acting, goes back. That means this particular tiny vein is supposed to accommodate little more blood to allow the backflow. That means what will happen now? What is it passing through? It is passing through the deep fascia. So there is a hole. Normally if you palpate your own long saphenous vein, you cannot feel any of these holes. All of us are having this perforator, but then we are not able to feel the holes. Why? Because they are imperceptible. But when there is an incompetent perforator, this hole becomes big and you will be able to feel it. Okay? At the same time, at that particular place, you will be able to see a dilated vein. I will show the incompetent what I mean by blowout. Okay, that is there in the next picture. So, but I wanted you to understand what do we mean by blowouts or incompetent perforator. So, what you are actually feeling here is this hole in the deep vein and a blob of big vein sitting there at the site of incompetent perforator. Okay, so that is a blowout. Same thing is not very much seen here. Because there is not a single vein, the vein immediately breaks within the muscle. See, there is a vein, perforator here, but then it breaks into multiple venous channels within the muscle mass. Okay, that what is the calf muscle? The soleus and the gastrocnemius. Then they again get together to form another venous channel and then they open into the deep vein. And the importance of this I have already told you because they are the seat of deep vein thrombosis. Okay, so that's about the communicating vein, relation of superficial and the deep vein. So now see this, what has happened here. So what you understand by varicose veins is what happens to the deep vein or superficial vein. The superficial vein becomes dilated, it becomes elongated. That dilatation has to be accommodated within the body or within the subcutaneous tissue. So first it elongates, it dilates, and then it also sorts of folds on itself. You must have seen a large number of these people coming with such huge veins, isn't it? So this is what happens. Now, can you see this valves? Okay, this valve is supposed to accommodate or allow only unidirectional flow. Suppose now this vein is like this, the valves are working like this. Now suppose this vein dilates. What has happened? The leaflet of the valve are not in contact with each other. So there is nothing wrong with the valve as such, there is a mechanical incompetence and that is what happens. Okay, so this is how you explain the primary varicose veins. People like surgeons, people like the liftman, okay, those who require to stand for long hours, the vein ultimately will give away because it is sustaining the pressure. What kind of a pressure is written here? So if I am standing here, that means the point of maximum pressure in my leg is going to be the ankle region because it is sustaining that much pressure. Okay, so at rest, the highest point of pressure is the ankle region because there is a continuous venous column. But now this continuous venous column in normal person is broken down by presence of valves. Okay, now when I start walking, what is happening? My calf muscle pump is put into action. What is this calf muscle pump doing? Whatever blood is within the deep vein, at any given time there is blood in the superficial vein, blood in the deep vein. So whatever blood is there in the deep vein is pushed towards heart. At the same time the valves are open, it sucks in the blood from the superficial venous system. There is another image in the next. See this. So this is at rest. At rest, see all the valves, this is open, okay, in the deep system there is a continuous column, this valve is closed, this is a superficial venous system. Now this muscle pump, so this is at rest, there is a venous column, there is a pressure in the venous column, okay. Now the calf muscle pump is put into action. When this is put into action, the valve towards heart is open and the blood within the deep system is pushed towards heart. At the same time, the blood from this will go into the superficial. So there is no backflow allowed. When this muscle relaxes, the blood from the superficial will go here. When this muscle relaxes. So this I am standing, then I am walking, and when again I stop, this muscle pump is relaxed. Okay, and blood from the superficial venous system will go here. So in between, so there is a sucking action during contraction from the superficial to this and towards the heart. Okay, this is how it is working. So what is happening? The pressure changes. So my pressure at the ankle right now is 100. When I start walking, the pressure will come down. because the blood from the superficial is going into deep to heart. And this pressure drop will take place within 30 seconds. Okay? In a normal person. Okay? So this pressure will reduce. So why do we need to know this? To differentiate between a patient of varicose veins and a patient of PVD, arterial disease. In an arterial disease, the patient will complain of pain when he walks a certain distance. Whereas in varicose vein, the pain will reduce. He is stationary, so they complain of tired legs. Isn't it? By end of day, it is classically, the varicose veins is classically called as a tired leg syndrome. Why? Because towards the end, the person is standing for long hours. Dukandar astat. Maximum of my patient in private are all these shopkeepers who are standing there for long hours, who have minimum mobility. They are just standing behind the counter. So towards the end of the evening, because they have been standing for long hours without putting their calf muscle pump into action, they feel very tired and they have lot of pain. Okay? But then they realize that if they lie down, if they keep their leg up, that is, you are aiding gravity for the venous drainage. Isn't it? Now, because they are standing for long hours, they have varicose veins. The blood is having a continuous venous column with a pressure near the ankle. So, the moment they lie down, lift up their leg above the level of heart, the blood flows towards heart and they feel little better. Okay? So, that is what is happening. So, this takes place in a normal person. Now, imagine a person who has incompetent perforator or incompetent valves. What will happen? Every time the little amount of blood gets pushed towards heart, little amount of it leaks out. And then this thing will progress and you will get all the changes of varicose veins. So that's why you get changes around ankle region. Whenever you're talking about varicose veins, yes, the patient will be complaining of those dilated veins. But what you see maximum is the pressure changes or skin changes around the ankle region, because obviously it is the point of highest venous hypertension. Are you with me? Okay. So, little bit of epidemiology. This is absolutely commonly seen. It is much more common in females. Okay, maximum. So, this 30 to 40% in women, yes, it is seen. Though we feel that whatever I am talking about, the professions that I am talking about, shopkeepers आहेत, त्यानंतर liftman आहेत, किंवा watchman आहेत, all of them are males. But then, still, if you compare the incidence is more in females. Okay, and that is the presentation that you get. What are the kind of presentation you see in your practice of varicose veins? What do they come to you with? Can you tell me? Pain, yes. Then eczema, skin changes, yes. Then ulcers. Okay, so that is what. You agree with this slide? Okay. So basically the patient comes to you with cosmetic reasons and he also comes to you with impaired quality of life. Okay, so the patients in whom we do laser or radiofrequency ablation, next day they say our tired feeling is gone, because that venous column is totally removed. The high pressure venous column is taken care of. Okay, so they improve immediately. They come to you for quality life because they are feeling tired by the end of the day without doing much. Okay, so that is what is their complaint. So warning signs are heavy tired leg, unusual warmth. Many of the sensitive people will tell you that they become very warm towards the end, especially women will tell you that. Okay, then tension, cramps. What is the question? When do they get cramps? They usually get night cramps. Why night cramps? Because daytime the veins are dilated, full of blood. They are increased in size. When the patient lies down, suddenly this pressure goes and suddenly the vein collapses and that stimulates the vasa nervosa of the vessels. Okay, that's why they get those classical night cramps. Okay, feeling of dragging pain in the calf area, swollen ankles, earliest. You know that there are two types of pressures that blood inside the vessel exerts. One is the colloid osmotic pressure and a hydrostatic pressure. So what is more here is the hydrostatic pressure, pressure of the venous column, And that ultimately leads into ankle edema. The first thing that it will start leaking out, isn't it? The fluid starts leaking out. So it's not only the fluid that leaks, that is followed by the cells. The earliest cell that comes out is WBC, always, followed by RBCs. The RBCs also come out. These RBCs, they come through those gaps. There is an increased hydrostatic pressure. The pores in the smaller vessels around the ankle, because there is a main vein, then smaller venules. Okay, they are also experiencing increased venous hypertension. So their pores open up. RBCs come out. RBCs will die in the periphery. The the pigment inside is converted into hemosiderin. Okay, this is the hemosiderin which gives rise to that irritation. Okay, and the patient has eczema. He starts scratching. So first change that you see is the patient will have ankle edema. This ankle edema now starts changing color. Why? It is because of the hemosiderin which is coming in the periphery from the RBCs. This hemosiderin starts irritating the nerve ends and the patient starts having the scratchy sensation. He starts scratching. Okay. Now I told you about two components of blood that have leaked out. The third fellow also comes out, that is the fibrin. As soon as the fibrin comes out of the blood vessel, it becomes fibrinogen and it starts coating the vessel. And this coating further hampers the oxygenation of the peripherals. Okay, and that is what forms the basis of your ulcer. So one, there is edema, followed by there is pigmentation because of hemosiderin, followed by scratching, eczema, plus the oxygen tension in the local area becomes reduced. So they have ulcers. Classically, the venous ulcers are superficial, but still they don't heal very well. Why? One, you have not treated the cause of venous hypertension. Second, this fibrinogen coating. If you feel the limb of this chronic venous hypertension patient, you will be able to feel the difference. It is woody. Okay? It feels different because there is fibrin deposition. Lipodermatosclerosis. I know these are big words, but simplified. I have given you the simplified answer to it because it is the blood products they have leaked and they are totally managing the show around the ankle region. Okay? So that is how all these complications of venous vein or the presentation of varicose veins is. This is just a theoretical side, but I want to draw your attention to these risk factors because these are the patients who will be coming to you regularly. These are your regular patients. So you have to be aware. Many of these females during pregnancy will come with varicosity and they are reversible. But subsequent pregnancy, the varicosity may remain. They come with huge, big size varicosity, even the vulval region. Okay? But you have to just reassure this patient. They usually go back. Why? One is the hormonal effect of progesterone and plus the baby's head. I think I have this slide. Anyway. So one is hormonal effect which relaxes the blood vessel wall and plus the pregnant uterus, the baby's head presses onto the compressible veins in the pelvic region and this is what adds on to the varicosity of the pregnancy. Okay, so that is one thing that we need to remember. So pregnancy, if this lady who has already developed varicose veins comes to you with tired leg, take it very seriously, look for deep vein thrombosis. Because we already know that they are more prone to develop deep vein thrombosis. They might have had some episode, okay, which has predisposed them. Even pregnancy itself has predisposed them for deep vein thrombosis and these patients should be under surveillance. Okay. Then surgery or trauma, post-op patient following up with you, especially those who have undergone a pelvic surgery or a lower limb surgery because they have been recumbent in bed for a long time. Such patient coming to you with some trivial ankle edema, look for DVT. Because that is going to give rise to, that is going to sow the seed for further varicosity or varicose veins later on. Okay. And then patients with hormone medication. You know that OC pills or hormone replacement therapy, they are more prone to develop thromboembolic episodes and they are more prone for DVT and then secondarily they may land up into secondary varicosity. So primary we all know, primary is idiopathic in people like us who are standing for long hours. All of us do know that. or you have congenital etiology also. Many of the familial members will come to you, but the congenital is usually seen at earlier age group. It is bilateral and the patient will tell you कि हाँ माझ्या वडिलांना पण होतं. Okay, so congenital is usually bilateral, will come earlier. They will not be so symptomatic, but they will have very big veins and bilateral without any reason. They may not be standing for long hours, but then they have this congenital problem, that is absence of some particular valve, and that's why they'll end up into development of the varicose veins. Okay, so that is the importance of this, because we have to look for these particular, or the follow-up of these patients is very important. So primary, I think we will go ahead. Secondary, deep veins. So what happens? Deep vein thrombosis. Now this we need to understand why deep vein thrombosis leads to varicosity. Deep vein thrombosis, so what is happening? The whole deep vein channels, basically the indirect perforators get thrombosed. Indirect perforator inside also are having lots of valves. So when this thrombus recanalizes, those valves are destroyed. The valves in the communicating vein also may get destroyed. The strategic valve, which does not allow a backflow, may also get destroyed. And that is how you get a secondary varicosity after DVT. Okay, not all of them may develop, but majority of them will develop. This is one important thing. Secondly, there is something called as a post-thrombotic limb. As surgeon, we are afraid of this, because suppose if we have not diagnosed post-thrombotic limb, that is a person who has undergone a DVT, valves destroyed, deep veins are incompetent. Now this cannot be tackled by a general surgeon. If a deep veins are incompetent and I remove the superficial venous system, either by radiofrequency ablation or laser ablation or surgically, then it is bad. This patient is booked for lifetime for a venous ulcer, because I have removed the superficial vein, the deep vein is incompetent, which is it will leaking the blood out. Okay, so this particular patients, they require specialized care by a vascular surgeon, where they treat the valves. They give them new valves or they do valvuloplasty. Okay, so post-thrombotic limb is something that we need to be aware of. A person who is having a long-standing ulcer, you have to go into depth. You have to find out whether in past he had some deep vein thrombosis, history of deep vein thrombosis, and assessment of these patients is very important. Otherwise, you will land up into trouble. Okay. So what is the best thing to give them is the compression stocking. Okay, for post-thrombotic limb. Either vascular surgeon, vascular surgery repair, or compression stocking. It will give them immense pain relief and it will also help in healing of the ulcer. Okay, but then you cannot remove their superficial veins. Okay, fine. So yeah, I think this was misplaced. This is the secondary varicosity because of pregnancy. We have already spoken about it. Yeah, this is just for a theoretical slide again. Nowadays, vascular surgeons or even general surgeons, we talk in terms of this. When we classify varicose veins, simple. CEAP. C is clinical, E is etiological, then A is anatomic and pathophysiological. So if you want to say that this particular person is having C this, E this, whatever, you have to have first a complete history of the patient, okay, an examination that will give you the clinical diagnosis. Etiology, from history you will get the etiological diagnosis. Anatomic, Doppler will help you the anatomic diagnosis, and pathophysiologic with reflux, without reflux, or with incompetent or without incompetent perforator. So that is the CEAP. But generally, when we are talking with general surgeons, general practitioners, we are not talking in terms of this. It is too much to remember, isn't it? You just say varicose veins आहेत, nahi hai, incompetent perforator आहे, nahi hai. Simplify. Okay? Okay, so this is CEAP. This is just to complete the slide. So, this is the progression I have described to you. So, what happens? Incompetent valves, there is either a reflux or obstruction, incomplete resolution of thrombi, chronic reflux, ambulatory venous hypertension. Have you understood the word ambulatory venous hypertension? Ambulatory, when the person is standing for long hour, is the venous hypertension that he is so that is what the patient comes to you initially without visible varicosities. The patient will come to you with this tired leg syndrome, and that is when you should be able to clench it with just simple ankle edema and this other signs. Okay, and you should send the patient for Doppler, establish the diagnosis. Okay, such patients might get away by certain change in lifestyle or simple Bisgard's exercises. So we will see now first the diagnostic method and the treatment. So diagnostic essentially duplex. So what does Doppler give us? Doppler will give us which vein, where, how long. The reflex is for how long, how many seconds. Okay. Then also most important thing for a surgeon from the Doppler report is whether there is any evidence of DVT or no. If there is an active evidence of deep vein thrombosis, we don't touch the patient. If there is a past evidence of deep vein thrombosis, we will look at the competence of the deep vein. Okay, we'll look at which veins are incompetent, which perforators are incompetent. So mapping of the perforator, so we can tackle it on table. Okay, so all this information, so Doppler study is the most important. Now can you read this? What is that blue and what is that red? On the right hand side, it's the saphenofemoral junction. So what does that blue signify and what does that red signify? Can you tell me? So that is a misnomer, or I would say a misconception that red and blue is not venous or arterial. It is simply the flow of blood as far as the transducer is concerned. So whether the blood is flowing towards or away from the transducer. Okay. Now why this is important? Because that is where you're going to diagnose the incompetence of the perforator. So I have the next, see this video now. I hope it runs. Okay, I'll run it on this. So basically, what it shows is there is actually a movie, small clip, which shows, one most important thing is whenever you're doing a Doppler for a varicose veins, the person is standing. Okay, and the ultrasonographer is sitting next to him and he is holding a probe at the saphenofemoral junction, which is 4 centimeter below and lateral to the pubic tubercle. What you do is, first you are keeping the probe and you are establishing you are establishing the flow in the vein. Now there is a strategic perforator which is sitting at the saphenofemoral junction. Okay. So if this saphenofemoral junction valve is incompetent, what will happen? What is the type of flow that this saphenofemoral junction should allow? You know there is a long saphenous vein which opens into a femoral vein. So the long saphenous vein is the largest direct perforator because it is communicating directly with the deep vein. Okay, and there is a strategic valve sitting over there. Now long saphenous veins dilates. It becomes huge. So what has happened to the valve? It has become incompetent. Now what this long saphenous vein, which is a direct perforator, supposed to do? It is not supposed to allow the flow from deep to the superficial, that is femoral back into the long saphenous vein, isn't it? So when I ask the person to do Valsalva maneuver, what am I doing? I am increasing the intra-abdominal pressure. Now if this perforator is incompetent, what will happen? There will be a backflow. And that is what is shown in this. So initially when the person is standing, you have put your probe on the vessel wall, there is a blue color because there is a unidirectional flow. As soon as I ask the person to do a Valsalva, there is reversal of flow. Okay. So this blue becomes red. Okay. So basically what you see here is, this is the deep vein, that is the femoral. This is the saphenofemoral junction. And can you see this? These are the valve leaflets. Here white display tumhala. So what happens is, सुरुवातीला हे सगळं blue दिसतं. As soon as the person does Valsalva, this particular column becomes red. That is, there is a reversal of flow. Okay? So what the ultrasonologist does is, first of all, he will establish that there is a reversal of flow, and there are also, they should measure the width of the vein. Secondly, for how long? 0 to 5 seconds, minimum 5 seconds. Why this is important? Unless it is this much, usually the patient is not asked to undergo some surgical or a radiofrequency ablation or EVLT. Okay? So there is always a person to person difference between the Doppler study. Okay? So optimal Doppler study should be done like this. Okay? It has to be mapped. You have to look at the time for which the reflux is. Up to 5 seconds, minimum up to 5 seconds that reflux should take place, and the diameter of the vein also needs to be measured, especially if you are trying to do a endovenous laser therapy or a radiofrequency ablation, because minimum 4 to 5 millimeter dilatation or the diameter of the vein is required for cannulating. Okay, smaller size vein with incompetent perforators can be tackled surgically also, but if you are planning a minimally invasive, minimum 5 mm diameter should be there. नहीं तो cannula जात नहीं. ठीक है? So not possible. Okay. I will try to see whether the video is running from my. Yeah, can you see this? So initially it is blue. As soon as पुनः run करा. Next video. Yeah. Yeah. So this is normal without Valsalva, and when the person is doing Valsalva, there is a reversal. Okay. Let's see the next. Can you see the reversal of color? Okay, so nothing has been done. Only thing is you are raising the patient's intra-abdominal pressure, and that reverses the flow. Okay, so that is what is important, and this reversal you have to see whether that reversal lasts for more than 5 seconds, and that becomes diagnostic. So this now, anything else you want to know about the varicose veins, the pathology? Questions that you have? Otherwise, we will go to the discussion of treatment. You have any queries as far as this understanding is concerned? Okay? One limb, yeah. So you can have differential dilatation of vein. So there is no specific etiology. Why this? Now, specific etiology will be applicable if there is a trauma to that limb, direct trauma to that limb, or fracture. Okay, so that limb has become immobilized for a longer time than the other limb. Okay, so that could explain, but that is essentially the secondary varicosity. Okay, fine. So management, essentially, if you have diagnosed the patient early, as I have told you, with ankle edema, with tired leg, okay, and the patient shows varicose veins, but then Doppler does not show much reversal. There is no perforator incompetence, though there is dilatation of vein. Okay. There is varicosity seen there, okay, everything is okay, you have caught him early, you can teach them Bisgard's regime and medical therapy. What is Bisgard's regime? Is doing what nature has given us, just reinforcing it. So what is Bisgard is? Ask him to stand or put his calf muscle pump into action every hour. This gives them tremendous pain relief. Every hour, now the person he cannot change his job. So when on his job also he can do this. So heel raises, it is called as heel raises. So when you do heel raises, you are reinforcing the calf muscle pump. Whatever venous hypertension is there, that is taken care of. Secondly, you should advise them that whenever you lie down, lift up put your feet higher up than the level of heart. That will also aid the venous drainage. So all these things, so beginning ankle edema, or there is something called as ankle flare. What is ankle flare? All of you can look at your own limb, see the medial malleolus. Please see the medial malleolus. Just below the medial malleolus, there is a hollow. Isn't it? Khadda aisa. So what happens, I have told you that venous hypertension gets carried up to the periphery. So this hollow gets filled up with small venules. Okay, and that is called as ankle flare. So that is, so after ankle edema, next is ankle flare, then there is pigmentation, then there is eczema, ulcer formation. Okay, yes sir.
How often is to be done and how long?
Daily they should do it, and at least 3 to 4 times per day, minimum. Jasti वेळा केलं तरी there is no harm. But only thing is, clinically rule out DVT. नाहीतर आपण आपलं thrombus पाठवून देऊ वरती. ठीक आहे? So clinically rule out DVT before advising this. Okay? Fine. Next is medical line of management. Medical line of management, we are not giving so much. Yeah, there is a level of evidence, grade 2 recommendation, level B. So when are we giving this? When we are treating the patient of ulcer, say, conservatively, okay, or the patient is not willing to do anything else. Thoda sa placebo sarka hai, but yes, it does help in healing of the ulcer. But totally, it will not take care of, because you know you have not taken care of the pathology that is there. So it can be an addition to whatever else you are managing. Okay? So totally medical management वर सगळं चालणार नाही. ठीक है? So that is medical management. So you have phlebotomics, diosmin, all these drugs are now in vogue. So flavonoids, okay? So that is medical therapy with discharge exercise. So that is the first line of management, especially in patients who don't have much cosmetic problems or who don't have any ulcer. Ulcerच्या patientला discharge वगैरे, it will help, but then maybe during the preparation of the patient. But that is not the first line of management. Next is compression stocking. This is quite a big mainstay of the treatment for varicose veins. Not all of them will give consent, or not all of them do require surgery or any other intervention. Compression stocking is the thing. Like when you are managing the patient conservatively, but not just any stocking. They have to be proper stocking which will exert pressure to this level. Isn't it? Because without that, now this stocking is supposed to aid the calf muscle pump. It has to exert this much pressure, otherwise it's of no use. साधे कुठलेही stocking ladies से वगैरे घालून फायदा नाही. It will give a placebo effect to the patient. No. So you need to have proper stockings. So we have various types of stocking. We do have Indian stocking, but their life is very small. पण ते 800 रुपयाचे आहेत. आपल्या पेशंटला परवडत नसेल तर 800 रुपयाचे स्टॉकिंग द्या, but then they will require frequent changes. If they have lost their elasticity, they are not working. Or you have other company, the foreign companies like Sigvaris, which are very good stockings. Okay? Then do you have now this ulcer X? So if you have a patient with ulcer, venous ulcer, okay, also these stockings help. It can help in total healing. So this patient has not been operated, no radiofrequency ablation done, just use of ulcer X stocking, which is a double layer stocking. Only with that also the ulcer will heal. Okay? So those patients who refuse or who are not fit for surgery, stockings will definitely help. So stocking has a very big role to play in management of varicose veins. Okay? Next, surgical management. Now can you appreciate these blowouts here? Can you see this? So this is how, this is the ankle perforator, site of ankle perforators. There is a huge dilatation. Who has marked this? The radiologist. They will mark the whole course of the vein, and they will also mark the site of incompetent perforator. Because what we are supposed to do, we are supposed to remove the vein. This is the flush ligation. This is a incision for saphenofemoral ligation. So this is where it will come from the medial aspect and it will open into the femoral, and near the, so this is the saphenous vein, and this will be the deep vein, and these are the last tributaries of the saphenous vein before it just opens into the femoral vein. So you are supposed to do flush ligation. That is, take care of all the small veins. जर मी इथे हे ligate करून टाकलं तर the saphenofemoral junction remains. And this is what is responsible for recurrence. So it has to be flush ligation, just where it is opening into the femoral vein. And you have to take care of these tributaries which open just before it opens into the femoral vein. Okay? So this is flush ligation plus After that, so this is the opened up saphenous vein. We put a stripper. So this is a stripper that you see. The stripper is passed from above down right up to the ankle. Once we have done everything else, and then we just pull it out. Strip. Purnacha purna vein nighun yete. Okay? Why? That is what is important. That is what will give pain relief to the patient, because that whole venous column of hypertension is removed, and that will give extreme pain relief to the patient. Okay? What about venous drainage? There are other veins which are there which will take care, and you know that the deep veins are the major venous drainage of the lower limb. So removing, so all these questions you can answer to the patient that removing this particular vein, which is as it is nothing but a tube without any competent valves, is not going to harm the patient unless it's a post-thrombotic. Okay? So this is about the surgical treatment. This is another type of surgical treatment where you're tackling the perforators. What are perforators? Those are the communicating vein between the superficial and deep. So what you see here is this is the ankle muscle. Okay, so actually there is an incision taken just behind the anterior border of the tibia. And this is the deep fascia. Can you see this vein? So beyond this is the skin and the superficial vein. And this is actually you're looking inside, deep to the deep fascia. See this could be a type of indirect perforator. See this, it is going into the muscle. But then there is a single venous channel which is communicating, and can you see this hole? Such a big hole. So this is an incompetent perforator which you do subfacial ligation, that is below the deep fascia. So this is a classical example of subfacial ligation of the perforator. So along with flush ligation of the saphenofemoral junction, you do subfacial ligation, and that is what is a complete surgery for varicose veins. So that is why this particular thing is very, very important for surgeon. That is mapping of the long saphenous vein beforehand, on the previous day or on the day of surgery. Because that will tell me where I need to take my incision for the deep fascia. Okay? So this is the saphenofemoral flush ligation along with subfacial. Now this subfacial ligation can also be done laparoscopically. Scope it is going deep to the deep fascia, and this is the inside. You are within the deep fascia. This is the muscle. This is the vessel which has come across. Okay? And you just ligate it. So there is a limited pneumo, which is created below the deep fascia. It's a closed compartment. Deep fascia is a closed compartment. So you enter with your scope beneath the deep fascia, inject air there, so it becomes bigger in size, and then you will see it becomes very easy actually to ligate those vessels. But then it requires a expertise, because it's such a small area to create a pneumo. Pneumo is injecting air. Okay? Surgery, so recurrence is 30% at 1 year, 40% at 2 years. What is most important is, now we are going everything towards minimally invasive. So this major surgery, it was our bread and butter of a general surgeon. This major surgery, it has its own problem that you have seen the incision is in the groin, and it is always surrounded by all the lymph nodes. So all these wounds, they weep for a long time. Lymphoria hoto tenna. They weep for a long time, and there is a definite increased morbidity, and hence what we have is the all minimally invasive things. Okay. In addition to the minimally invasive, before even invasive, minimally invasive, what you have is for minor small vessels, not a big vessel involved, you could do sclerotherapy, and the latest in the sclerotherapy is foam sclerotherapy. Sclerotherapy, what do you understand by sclerotherapy is you inject a sclerosant material. Polydocanol commonly apan vaparto. Initially when I was a resident, we used to use STS, that is sodium tetradecyl sulfate. Nowadays we are using similar material, polydocanol. But then instead of using the 1 cc of polydocanol, what we are doing is half a cc of polydocanol, take air. So half cc is taken in the syringe from the ampule, take air, take 2 syringes across a 3-way and go on pumping. So you create a foam. So from half cc of polydocanol, you create 10 cc of foam. So advantage of this is, one is the foam is even smaller in caliber. ते जे foam म्हणजे चक्क face असतो, which is much smaller in size than the fluid. So it goes even in the smaller vessels. Secondly, the amount of sclerosant that you are injecting is even smaller. Okay, so foam sclerotherapy is the latest. आता मी तो video नहीं आणू शकले. Next time if I come for NEA, I can show you the video of foam sclerotherapy. So it has become more safe. Foam sclerotherapy. Now there are, if you go and read on a net, foam, the moment you inject, within 4 seconds it goes into heart. But since, because it will go, it's a continuous channel. So you try to prevent that by blocking the saphenofemoral junction, just raising the limb. Foam is lighter, isn't it? So when you raise the limb, as soon as you inject, you raise the limb, it should go higher up. It should remain there. So that is how you will minimize the foam entering into the heart. पण तरी एवढ्या मोठ्या 5 लिटर मध्ये थोडासा foam doesn't make any difference. There have been very, very rare events of foam going into the brain and giving rise to a momentary TIA-like symptoms or a momentary weakness. Okay, so these episodes are known, but they are very trivial. Okay, but foam sclerotherapy is the biggest available now. So you should use it judiciously, and this is a outpatient department procedure. Okay, and foam sclerotherapy, another indication is for recurrent veins. Okay, so I don't know, because of the veins you are not able to appreciate. So hey, you see the empty vein here. Can you see? Appreciate the empty vein, and this is what the foam looks like. White, very vibrant white. Okay, you can actually do it under the ultrasound guidance. You have to do it. Why? Because you should see that there is no extravasation, because that will give rise to a very bad thrombophlebitis-like action. So this is example of foam sclero being given. See this is how the appearance is. Now this is endovenous laser therapy, the latest. This is not the latest. Now what you have is radiofrequency ablation. So basics of this latest minimally invasive therapy is high temperature is used to cause endothelial damage. Okay, so what is done here is, sorry. So can you see this? So this is the cannula through which, Seldinger technique ne, you will cannulate the vein, you will pass the, this is the thread or the laser fiber, and this is the tip of the laser fiber. Okay, so when you are withdrawing the laser fiber, you are giving the energy. And the moment you start withdrawing, it will give the specific amount of energy to the vein from inside. Okay, so there are steps in doing this. Yeah, this is the mechanism. Rapid heating results in boiling of the blood, generation of steam bubbles, collagen contraction, and fibrosis ultimately. This is the basis or the function of endovenous laser. Okay. Yeah, contraindications. I think this is all theoretical. Yeah. So this is actually the procedure. So this is the marking which is done pre-operatively. All these small vessels are also marked. So this is the cannulation. This is the laser fiber. This is the laser machine. If you see, this is the laser fiber that you see on ultrasound. And this is the saphenofemoral junction. He is a femoral ahe. This is saphenous. You keep it at a distance of around 2.5 centimeter from the saphenofemoral. Otherwise, there is a thrombus sitting over here. Far jar close dila, this thrombus will be sort of hanging into the femoral vein. We have seen that in our initial cases also, and then you are so scared that that thrombus might just go and into the heart. Okay, so this has to be maintained, and then while withdrawing, you give the laser energy. And then this is a surgical procedure which is called as a phlebectomy, ambulatory phlebectomy. That's for that only we are marking all these small veins. So what is done is, a stab incision is given. There is a special instrument called as a venous hook, which is not available in India. We have to get it from outside. Unfortunately, it's a very simple instrument, but yet not made in India. With the help of hook, you hook the vein up, these small veins, because the patient is bothered about all these dilated veins. He comes to you for cosmetic reason. So you give a stab and you take out the vein segment like this. Okay, and that gives them the best cosmesis. So there are some, can you see this? Can you see this? So you just pull out and pull out the segment of vein. It will bleed for some time, but veins undergo contraction. So you have to just maintain the pressure and the bleeding stops. So there are few of these results. Okay, can you see this huge? I think you must be coming across such kind of people. All these are managed by main segment by EVLT, endovenous laser, and all these segments are removed with the help of phlebectomy, ambulatory phlebectomies. Okay, so if you are interested, this is the large dilated vein, and here is a fibrous channel झाला. Once you have done a endovenous laser, at the end of 1 month, you don't see any channel there, no vein there. It is totally replaced by a fibrous cord. All these are pre and post-op. Can you see the amount of the huge size of these veins? But still they can come out. This is how the limb looks. See this, the healing of the ulcer. And we don't promise much, but the color also improves. आता हे बऱ्याच वर्षांचं झालेलं आहे ना. If you see this blackening, okay, but then it improves but doesn't go back to normal totally. Okay, yeah, this is another interesting thing to show you. This is how it looks on the Doppler. So this is your deep fascia, this is your superficial vein, this is the perforator. Okay, and here deep vein. So you have a laser fiber, a very smaller size laser fiber, which you can ablate this here. Okay. This is that smaller laser fiber I was talking about. This is the blowout, and we are ablating the perforator. Okay. So outcome analysis, it is much better than, anything which is minimally invasive is going to be more acceptable. The only biggest downside is the cost. Okay, because each of the laser fiber, now the cost has also increased 22 to 34. Even in Bharati we had a demonstration, so maybe along with radiology we are planning to sort of maybe get the laser machine or something like that, but then it is still under planning. But then that will be a good thing to have, especially in a tertiary care like a hospital like us, because it has some other applications also. Okay, so I think these are the facts. You all know that, yes, laser therapy, it will have little recurrence, but the recurrence rate is very, very low as compared to surgery, and biggest advantage, minimally invasive. That's the tagline nowadays, minimally invasive surgery, minimally invasive applications. Okay. So long-term results, if you see in surgery, it was 70 to 75%. In laser, it is almost as good as, and even in radiofrequency, as good as 90%. Okay. So that is, these are all advantage or benefits of endovenous laser therapy. Reduce morbidity. It's an outpatient procedure. Okay. Only thing is, because patients cannot afford, usually our insurance covers it, and for that purpose you may have to admit the patient. Okay. And radio frequency, new star on the horizon. It has advantage over laser that it gives even less amount of ecchymosis. Okay. In order to एक थोड़ा सा steps तुम्हारे सांगते, you have cannulated the main vein, you have placed the tip of the fiber at the saphenofemoral junction. After that, you are supposed to inject fluid around the long saphenous vein, which forms a sort of a water shield around the vein. Because you know the amount of energy that you are giving, the temperature rises to much more than 100. And this temperature dissipation should not take place in the surrounding tissue. So you create a tumescent anesthesia around the vein. So after you have cannulated the vein, you give tumescent anesthesia, that is fluid around the long saphenous vein, that prevents the dissipation to the surrounding skin. Okay, and this particular thing is quite less with radiofrequency as compared to laser. Initially we used to see a lot of ecchymosis on the patient in whom we have done laser, but in radiofrequency not a single patient with any pain sudha, because ultimately that vein becomes cord-like. So that is more in laser than in radiofrequency. Okay. So again, so whatever is latest usually has least side effects. Okay. Recurrence rate, सगळ्यांमध्ये recurrence rate आहे, but then recurrence you can take care of by say a foam sclerotherapy. Okay, but then the recurrence will come very late. So foam sclerotherapy or repeat EVLT. If you have a huge segment which has recurred, in my own relative, she was very, very fat. Okay. We were not able to give her a stocking of her size. So there was a recurrence in the last 10 centimeter of the long saphenous vein. Okay. So that we tackled again with another laser therapy. Because there was no way we could tie or could maintain a pressure, because immediately after laser sclerotherapy, you are supposed to give them again a compression stocking which they are supposed to wear for minimum 1 month. Okay, so that was not possible in that lady, so we knew that this was going to recur. Otherwise, the recurrence is not much at all. Okay, so to summarize, it's a common problem. More and more patients are now coming to surgeons where they should be landing up. Surgeons' work is getting eaten up by interventional radiologists, by vascular surgeons, by radiologists also. Okay, but then we should hold our territory and we should work along with radiologists. So this is my husband and me. Okay, why I showed you this slide? Because I had presented this in Massicon many years back in 2011. So there, just to get some light movement in the end, I said we are the Jodi number 1 because my husband is a radiologist and I am a surgeon, and we can give a complete package. Basically, it's a surgeon who is able to give a complete package, but in varicose veins management, the incorporation of a very good radiologist is very important. Okay, abroad where